Oh, hey, Chris.
Hey Chuck, how are you?
I'm great. I'm great. It's fellowship weekend here in St. Louis.
It is. So this will drop next weekend, the first true weekend of August, but we are recording the week before, and we had our graduation for our fellows last night, and we're doing a welcome for our incoming fellows and a farewell with the outgoing fellows with families and kids and all that kind of stuff um, later today. And it is really, really hot outside.
Yeah, my wife is a New Englander. I'm from Alabama, and usually the hotter the better. Like yesterday, I was out and about, kind of peak heat, and enjoyed it, like literally. And then this morning, I went for a bike ride over to a friend's house about a mile and a half away. So not a huge bike ride, but it was like 8 in the morning. It was unbelievably hot. Like,
Yeah, we've been having these super hot days. For reference, we're hovering in the 9 Celsius, folks. That's 35.
can
So
you start over? It
sure, sure.
like
Um,
um
I can start over.
okay.
It's crazy hot. I mean, we've been hovering in the 90s for those in the Fahrenheit crowd, and the 35, 36 for those in the Celsius crowd. You'd be very proud of me. I actually looked that up. Uh, But we had a couple of days earlier this week where we had a reprieve and it was beautiful. And it was like
Incredible.
70 degrees in the evening and you're sitting outside and enjoying the night. But now it's just sweltering. I was playing tennis this morning and I was wondering why my shots were so bad. And I'm normally not very good, but I realized that every time I tried to hit the ball with any sort of pace, my hand was slipping on my racket. And I was like, I am not that weak, like in terms of grip strength. But then I was like, oh, my hand is slipping because I'm sweating so hard, my clothes are drenched, so I can't even wipe off my racket or my hands with anything dry. So it was a disaster. Great sweat though, it was super fun.
Right. And so Talia and Macy, my wife and daughter, are doing tennis lessons together, which is great and hilarious. And they were at Forest Park with an instructor playing, and they, sweat so much. And I'm like, that's the whole point. Like, it's fantastic. Anyways, it's hot and it's humid. Um, and yeah, I generally love every minute. It's just a little too much humidity really today.
Yeah, well, I'm glad our new fellowship director, Dr. Brogan, is hosting the barbecue, and traditionally that's been a pool party, and that would have been the wrong thing for today. So
Yeah.
it'll be super fun.
So, if I may, I am always intrigued by billing and coding. I'm intrigued by payers, etc. And so, CMS dropped their planned 2027 both conversion factor, which influences how much we're paid, and some little tidbits and I have to say, I'd love to share those if that's okay with you, just briefly. And some of our readers may have some comments, and we would welcome an email with any comments from readers. So the first one and the most,
Hold on. Before you do that,
yeah,
two things. I do want to tell people because if you're about to fast forward throughout this entire episode, there will be some clinical content, listener mailbag that we're going to go through. We'll do a couple of thoughts for our new fellows starting out. I just didn't want them, the people that don't like the policy stuff to completely fall asleep. But that being said, CMS, and for those outside of the United States, that's the Center for Medicare and Medicaid Services. So they kind of set the bar for how things get reimbursed for the government insurance in the U.S. So Medicare is for those over 65. Medicaid is a state by state program, but is for those that are financially not doing well. And then, so they set the bar, and then private insurers tend to follow kind of the bar that CMS sets. So every year there's a new fee schedule that comes out, which causes all sorts of consternation because if you adjust one, you're going to have to adjust another. So say like you think we should get paid more for a certain procedure, it's got to come from somewhere because it is literally a zero sum game. So it might come from within the world of hand surgery or within the world of orthopedics, or you might be robbing from neurosurgery or nephrology or something else.
yeah, both caveats are great. So thank you for saying that. And the those from outside the United States listening may find this appalling, may find it fascinating. Um, our United States system is broken on so many different levels, and this captures part of it. But your mention of a pool of money that theoretically doesn't get any bigger is really an important one. So there are winners and there are losers. And, orthopedic surgery is a loser for 2027. If this holds, if Congress doesn't act, et cetera, et cetera, plastic surgery is a loser. So orthopedics is projected to go down by 7% overall.
Oof.
So inflation's up, comp is down, or reimbursement for CMS procedures. Derm and ENT are projected to go down 9%, so dermatology and
Whoa.
otolaryngology. Plastics overall is down 3%. And most importantly for us, hand surgery is projected to go down 5%. So before I tell you why that is, I think the most interesting one is joint replacements. So hips and knees, which have just been decimated over the last 20 years. And one could argue and make a pretty good argument about that they were way overpaid in the past. But the reality is work RVUs for a total knee um, are decreasing this coming year from 19 to 16, simplified. So three less work RVUs and a lower conversion factor. And so it's 500, basically $500 will reflect the work done of pre-op, surgical intervention, and 90 days post-operatively for a total knee replacement, and a hip is about the same.
And
And so
that's just the surgeon side. That doesn't include hospital, et cetera. But just to give you a frame of reference.
just a frame of reference. Where hand surgery is affected is this new proposal, which won't just affect hand surgery, but the modifier 25 in our system implies you do one thing on a day and you can also do another thing. So most pertinent for us is we see a new patient, they have CMC arthritis, we discuss options, we decide to give an injection. Moving forward, if this is accepted, then we will only receive 50% of the work effort slash reimbursement for the lower value of the two. So either the injection or the visit. And that will hit hand surgery hard. And that is the
Right.
main reason. Interesting.
Wow. That's crazy. Okay, well, hopefully none of our codes are getting devalued otherwise.
Well, the efficiency thing, there's a minus 2.5% efficiency, like basically saying, well, surgeons are getting so much more efficient, and the AMA has not been updating the code, so we're going to dock you another 2.5%, just like last year. Last year, they docked us 2.5% overall, but Congress put in a plus 2.5%, so we didn't feel it. But this year, we don't know. So it's interesting. Clearly, things have to change in our healthcare system. I don't personally believe this kind of gets it right, but it's coming in some form or fashion.
Oh, our system is so far beyond saving without imploding, completely imploding, that it's unfortunate. But anyway, there are some very amazing things about the American healthcare system, but the way that we do things, compensation is not one of them. I guess my last follow-up question would be if ortho's down, ENT is down, plastics is down, derm is down, who's up?
Yeah,
Neurosurgery?
neurosurgery's down a touch, as I recall. As you might imagine, the non-technical fields are up. There are some like vascular surgeries up 3%. There are some exceptions, but in general, the surgical specialties are down, and the non-surgical thinking specialties are up.
And some would say that perhaps that is appropriate,
Yep.
but it is, obviously we're biased as surgeons, but you do feel that, and I think that fortunately for the surgeons, the orthopedic pack is one of the biggest, if not the biggest, compared to the AMA. And I know the Hand Society is stepping up their efforts. We got an email last week about this and saying that they're aware and they're processing, and the Hand Society really has invested in the Government Affairs Committee, and now we have a policy fellowship, I believe.
We
So
do.
I think going in the right direction, something that we need good people doing.
Yeah. And last time with Kathleen McEwen, we talked about a Substack that she recommended. For this, I think the person who gets, and I may have mentioned on this podcast before, the person who gets this and shares it in a very digestible way is Christian Pean. I hope I pronounced his name correctly, from Duke. He's a trauma surgeon. He's really good with AI, but he's also good in this domain. So it's worth looking up and reading. He has a paid and unpaid, option on Substack, but really good stuff.
Christian, you are not listening, but I do remember the times that you and I spent together working in Dr. Carlson's lab when I was a resident and you were a medical student. And I remember watching him match and having a beverage with him at the academy one year. It's been great to see his career evolve because I'm the old guy now, so I get to see the people that I've put effort into really take off and do their thing. And Christian went in a different direction, but is excelling in every way.
Well, I'm a fan. So yeah, it really
Well,
interesting stuff.
that's really the seal of approval that everybody is looking for. So
It's something I am. I do listen to what he writes. But hey, the upper hand sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
becoming a physician is hard. Finding the right job doesn't have to be. Join PracticeLink for free today at www.practicelink.com/the upper hand.
All
So I had a
right.
couple of interesting kind of quick hitting cases I wanted to
I love it.
share with you. And I went through a period of time where I took pictures of everything. And you would look at my phone and there was like pictures of cases, of x-rays, of outcomes in the clinic. And then I kind of like had my whole bank of things for talks. So then I stopped taking pictures. And now I'm like, I need to take more pictures. So now I've just, in preparation for today, was scrolling through my phone and kind of thinking about recent cases. So one case I wanted to ask you about is, say it's a phalanx fracture, say it's a P1 fracture in somebody who has just, it's minimally displaced on the X-ray. It's one of those kind of longer oblique ones where you're not quite sure where the fracture line begins and ends. Um, Overall, the alignment is fine on the X-ray, but they've got just enough of a rotational deformity where you can't talk them out of surgery, which I tried to. How do you think about how to approach that type of P1 fracture with the rotational deformity that is not crazy bad, but is bad enough for them to want something done? Because I find it's kind of challenging, because I think you can go in there, get the fracture as right as you can, but then miss the boat on the rotation.
I think it's actually a really hard question. I'm actually touching on this. There's what I would used to call a symposium. I don't know what it's called today in the Hand Society, but there's a symposium on like pearls. And I have to give, I think it's 10 pearls in 10 minutes or something like that. And there's a bunch of us going. So it'll be rapid fire. And one of them is, first of all, evaluating for rotation or deviation with phalanx fractures. And so, how do you do that? Well, I try to do it in extension. And if the patient's willing, and a little bit of flexion, sometimes squeezing the forearm gives you a good sense. So, first of all, is getting a good evaluation and not letting swelling influence that. And then, second of all, and I'm totally dodging your question, but second of all, especially with kids, is do you care? Like, does the kid care? Does the parent care? What might matter to me might not matter to them. And so that is really important. But I think to get to your question, this is really hard. And I don't have any great pearls other than if the patient is unsatisfied with the clinical alignment and it's not on day one, the swelling's had a chance to go down, you really feel like you're looking at a real rotational or angulatory malalignment. You go to the operating room and you can sort of quote unquote mess around with trying a closed reduction to see if you can get it where you want it. But you just have to be careful not to fool yourself that you're making it better through the joint or holding the rotation. And for these, sometimes it requires an ORF, and it doesn't make it like perfect because even with an ORF, it can be hard. I just think it's a hard question. How do you think about it?
So your point about evaluation is critical. I think that when you initially do it, the contralateral side is critical. And having them not only make a fist, but slowly make a fist. And just because there are people that have a certain amount of physiological underlap, overlap, whatever it is, as long as the finger's not turning away from the rest of the fingers, you're really looking at these subtleties and trying to say, hey, like if we leave this the way it is, you will have this. I think you're going to be okay, but just know it's not going to ever look, the same. And then so having the other side, having it go slow, making sure the person that's with them can see it too. So just because again the patient is going through all this, like they're not processing anything, so they need somebody else see it. Um, but then I think I have not had great success with close reductions for this particular scenario. And I think in opening, it's really trying to fully appreciate the fracture. Where I think it can get away from you is that if you don't fully see where that fracture kind of comes around, and oftentimes because we're usually approaching from the dorsal side, it is on the volar surface. You can miss a continuation of the fracture and think you've got your screws where sufficiently, and then you do your rotation check and you're like, oh, what happened?
Yes, these are just hard. I like everything you said. I absolutely have had cases, whether metacarpal or phalanx fractures, where I get what I think is an anatomical reduction through an ORIF, and then I take a second and look at the finger, and it's 20 degrees off. So they're just hard, and I don't know which cases are harder than others. You think sometimes that a simple spiral fracture is quote unquote easy. It's not always easy. You think comminuted would be much harder. It's not always. So it's just these are ones you can't rush through, and you got to get it right.
Okay, so the other thing that came up twice in the last week is just for some reason I got the same fracture type of distal radius fracture. It's literally days apart, and it was a metaphyseal distal radius fracture in a and I won't say older patient, but both patients were in their 60s. Um, and metaphyseal distal radius fracture, intra-articular extension, both fractures splitting up between the scaphoid fossa and the lunate fossa of the radius. Pretty good amount of radial shortening, both dorsally displaced, and then the volar cortex was quite comminuted on the metaphyseal aspect and the expected dorsal comminution. The person that was with me, we were talking about the X-ray, and I said, "All right, how do you want to approach this, et cetera?" And they were like, "Well, maybe we could have gotten a CT scan." Um, and I very rarely will get CT scans now for patients with distal radius fractures. When are you still getting CT scans?
Yeah, I'm with you. I rarely get CT scans for distal radius fractures um, because I believe that X-rays, traction X-rays in the OR, and just clinical assessment usually is sufficient. It doesn't help me necessarily, and I would say typically, understand the fracture better or plan my surgical intervention. So without either of those, I don't do CT scans. So that brings up like scaphoid fractures. Again, rarely do I do it, but when I don't understand the fracture or don't have a sense of what I need to do surgically, that's when I get a CT scan. So I think a lot of our trainees are falling into the perspective that CT scans are always helpful. Our ERs often order CT scans we talk about this in the peds world all the time. It's just a knee-jerk reaction to order CT scans. And I don't believe that it's helpful for many of the things we do. So I would not do it either. I would plan my surgery like I normally would, which for something like this would be a volar approach, a reduction and fixation with a volar plate, plus minus a peak in the joint if I was really concerned about my articular reduction. Yes, you can put a scope in. Science may or may not support that, but I've been happy with that approach, and I think you do something similar.
Yeah, I mean, in terms of the CT scan, I think the only time it's uncommon. It's usually if I really am concerned about measuring the size of a volar lunate facet piece. But then again, I'm going to look at that directly in surgery if I'm that concerned, and I'm probably going to use fragment-specific fixation if it's really that bothersome of a fragment. On the dorsal side, concern about the fragment of Brogan, that kind of dorsal ulnar corner piece. Is that split in how many different places? Again, I'm going to be looking directly at that because I'm probably going dorsal for that one anyway. So I've stopped getting them as much. As a funny aside, my daughter sprained her ankle during an aggressive game of Duck Duck Goose while we were on vacation, and I was very, very confident that it was just a sprain; it wasn't a fracture. And she's actually here right now, and so I was confident in my assessment, but then it kept hurting. So I was starting to having my dad guilt. Maybe I'm missing a fracture. So I got an X-ray and I brought her in for the X-ray. One of our colleagues ordered it, didn't get her a full assessment. But I just got the bill for the X-ray. I was like, wow, did not realize. So so the X-ray itself was covered $120 by the insurance, but then, yes, I am. But then there was an additional $260 not covered by insurance, and that's just the hospital side. So I'm sure the radiologist bill is going to be good too. But imagine a CT scan, right?
Yeah.
So imagine how much that's going to cost both from the facility side as well as the radiologist interpretation. So um, this actually transitions me to our next question I had for you um, and topic for today. So you have people that are graduating, which means you have people that are starting in practice. And when you have people starting in practice, at least in orthopedics and in plastics too, I mean, you've got to start collecting your cases because you're going to be applying for the second step of your board certification. So I want to ask you how you tell our graduates to prepare for having data ready for, your board examinations because you know you're going to have to send it in a certain format. But before we dive into that, wanted to mention that Checkpoint Surgical is bringing together a panel of leading experts for a can't miss session at the Hand Society annual meeting, Advancing Upper Limb Spasticity Care. This is a case-based deep dive into how nerve-based surgical techniques are reshaping the way we manage upper limb spasticity. Real cases, real decision-making, real expertise.
I love the panel. You'll hear from Wee Lam, who's a really good friend of mine, Carolyn Leclerc, Peter Ree, and Sammy Tufaha. Join Checkpoint on Thursday, September 17th at 11:30 a.m. during the Hand Society annual meeting in Boston. Quite a lineup.
Yeah, absolutely. And we should mention, so speaking of Wee Lam, those of you that are in the UK and maybe those that are coming to the UK, the BSSH annual meeting is in Scotland in November, and there will be a live Upper Hand podcast.
There will be, and I'm certain it's going to be the most impressive um, site that we've ever podcast from. I am really excited about my trip to Scotland. My wife and I are going a couple days early to do a little driving tour. November may not be the best time to drive around Scotland, but we'll get a real sense of the place. And Edinburgh, as I understand it, is one of the world's gems of a city, so I can't wait.
I think it'll be super fun. I saw the promo emails that they were sending out, and they talked about American luminaries such as Warren Hammert and Chuck Goldfarb coming as part of the delegation from the AHS. I somehow was not included on that list, and I'm not offended. That's okay. But it'll be a really fun meeting, so hopefully folks are going to go. So back to the original question, board prep, because this came from a listener who I didn't ask their permission to say their name, so I won't, but they recently took part two of their boards, and they were just asking for tips on preparing for that exam. So it starts with the case collections and formatting your data in the right way.
Yes, and I think largely the boards have come and gone in the United States for orthopedic surgery. It's towards the end of July with in-person for orthopedics, in-person testing. You submit your cases. I believe still 12 are chosen, and you present on 10 of those. And yeah, this is hand surgeons by nature are anal retentive and very meticulous, and this is a time to let that side of your hand surgeon persona show. And so it's really about starting with the patient. So every patient you see has to have a really good history and physical examination and collecting the right data, whether that's radiographs or nerve studies. Those have to be in your medical record. I think it's fine to do the gathering of information later as you go, you're collecting the right things and your notes are full and reflective of a full train of thought on why you may be doing what you are doing, because those notes will be scrutinized. And no one should change how they're doing what they're doing, but it's just a matter of taking the right approach, collecting the data, and representing the data in the written notes that you provide. That to me is where you have to start. And if you do that right, everything else will fall into place.
So I'll put you on the spot. If you are starting your practice in 2026 and your practice strongly recommended or required you to use a bridge or any other sort of AI scribe type device, do you think that's good enough?
I think it's good enough. Yes, I do, as long as you carefully, make the notes your own. A bridge or any other ambient listening program provides a very good skeleton, I'll call it, for your note. And the HPIs usually are pretty darn good, but you have to review those and you have to beef up or expand for the clinical examination piece. I think that's just a necessity. But yes, there's no reason not to use those tools, but you're going to have to add to them.
And I would say if you're starting your practice, whether you're plastics or orthopedics, look at what's required, when you submit your cases or ask people from the last year, just so you can make sure to start collecting your data in that way. If it's not part of how you normally collect data, but obviously make sure to include that. And I know that in plastics, you've got to take pictures of everything, even patients with fractures, just because of the way plastics boards work. So, you have to prepare your patients in that way. But yeah, follow the processes, set it up from the beginning. I started, this kind of standard spreadsheet like you have for your, practice, but having the fields collected in a certain way to help out. So I guess if your cases are selected, you've got your 12 cases, how do you advise people to, prepare? Like, what do you obviously have to present the case in a concise way, but what are the resources you use? How do you get yourself ready for the exam?
You and I probably both helped previous fellows prepare. It's an annual kind of process where at least one, if not more than one, will ask my opinion and I'll run through the cases with them. It's always an enjoyable process for me. I don't actually participate in the real board examination. I've just never made that a part of my life. I think the people that do it find enjoyment. I guess I get my enjoyment from helping previous fellows do this. And yeah, I think as a fellow, or I'm sorry, as an orthopedic surgeon going for their board examination, you have to practice. It's not enough to think you know what the questions will be. It's a matter of being able to justify your thinking process and what is reflected on paper. And so it is also about, it doesn't matter how trivial things might seem, but if you have a trigger finger that's chosen for whatever reason, then know the current literature on trigger finger. Justify your decision-making process and be aware of the most recent literature is a really critical part. So yes, it's preparing great cases and being able to justify how you thought and acted through those cases, but also understanding the background information that justifies the same.
Yeah, you have to rehearse the presentation. No matter if you think you are slick at public speaking and you can think on your feet, practice this because this you get one chance. And once the examiner smells, they smell blood, like that's interaction. But if they can sense when you have not prepared appropriately, and obviously with human nature, they may go after you a bit. And you have to think about pretend as if the crustiest attending that you worked with and grumpiest is the one examining you and is going to ask you all sorts of weird questions. Now, it's not that way all the time, but you just have to be prepared for that worst case scenario. Somebody who is examining a bunch of people is probably hypoglycemic and undercaffeinated and just really wants to get out of there at that point of the day might be looking to pull one on you. So I think it is important to practice to, present these cases to people that you worked with in the past, whether it's your practice partners or your mentors from fellowship or residency, just to get a different perspective. Have rationale for every somewhat even close to important decision. Why didn't you give antibiotics? Well, before this surgery. Well, so and so the literature says this. And if it's not the literature, just think about, is this how my mentors did it in fellowship? And usually that's a good enough reason as long as you can rationalize it in another way. But like sometimes you just gotta say that's how we did it in training. And there were no issues with that. It's just being thoughtful. And our fellows that have, practiced with us in the past years are really quite good, about preparing. And hopefully it's just like that final run before they go in for the real exam.
Yeah, in the United States, what I understand the reviewers are looking for is ethical behavior, making patient-centered decisions, not decisions that may benefit the surgeon. There's an expression in the United States about don't be a cowboy, so don't go running off doing your own thing. Really, kind of just do what's accepted. And as we get older, you and I can do a few things in unusual situations that might not be the by the book, but based on our years of experience, might be justified. I still hesitate to do kind of crazy things, but in your first 2 years of practice, you should not be doing those things. And if you have a case that requires it, I think it's very reasonable to either involve a senior partner or send the patient to a senior partner. You're not trying to evade the eye of the reviewers. You're just trying to use expertise around you as you care for your patients, as you develop the expertise.
Yeah, two things to steal a line from your book. They have cowboys outside of America, so Argentina, Australia, lots of places, just
Thank
so you
you.
know.
Thank you for
And
clarifying.
Canada. But
France?
second
Does
thing,
does France have cowboys?
no, no,
Okay,
definitely.
okay. Well,
Well,
for my
somebody's got to
French
round up.
colleagues.
Somebody's got to round up, all the cows for the butter that's the wonderful butter that's made. Um, what you don't want to do is go in there and they ask you about this complication and how is it change how you approach things, etc. Just don't want to be that person that says, oh, that was just the cost of doing business. Can't do that. Just don't be a jerk, just be humble. All of us have complications. Be reflective, be contrite. Nobody likes a jerk. And again, people taking the board exams, you're probably not don't need that advice, but some of those people anyway. Um, I did want to pivot to an email that we got.
Can
Again,
I
did
interrupt?
I got
I want to pivot to the email too. But Chris and I were talking about what to share in this podcast. I think our next podcast might be kind of how to think about those entering fellowship. So maybe 10 tips for new fellows and perhaps 10 tips for new post fellow graduates. So we can share some of the things. We've done this in the past, but I feel like it's been a few years, so it might be fun to do that for our next episode in August.
I completely agree. I think that'd be super fun. It's crazy how long we've been doing the podcast. I'm reminded because we had lunch last week with a new therapist in the area, and I won't blow her up. Or actually, I think she's been listening. Hannah Osman, who's a certified hand therapist in the South County area of St. Louis. She's been listening to pod since we started. So she brought up a segment that we did a while ago called Seven Whack Gigs. Yeah, that's an old episode. But we used to go through, kind of different segments like Wheel of Hand Surgery. Yeah, those are old ones. But we can do top 10 tips for starting fellows and top 10 tips for new practicing hand surgeons. I think that would be super fun for one of our next episodes.
Yeah.
So we had a listener write in. Again, didn't have a chance to ask permission for their name, but they're practicing in the area here, a couple of states away, and longtime pod listener. So thank you for that. Who has seen an influx of patients with hypermobility, either formally diagnosed, self-diagnosed, or best yet, her diagnosing them with hypermobility. They tend to be young in their 20s and 30s and multiple complaints. This listener's questions are, what has been your experience with these patients? What counseling do you give? Any wound healing issues? And what is your system's ability to get these patients formally worked up? Big delays where this person works. They will do a bait and score in clinic, but that's all they're comfortable doing. And then the age-old question about what do you do for thumb CMC instability? As well as ulnar wrist pain. So love that last question for you especially. But I wanted to thank that listener for writing in and requesting the topic as well as the one prior about the boards, and would encourage anybody to write in with suggestions for topics to discuss, handpodcast@gmail.com. So Chuck, how do you think about hypermobility in general, and is that guided by practice or literature or both?
Well, it's a great question, and for me, there are two age groups that this is most pertinent. The first is, and they're both predominantly women or girls, and I would say the 12 to 14-year-old female and as the reader said, 25 to 35-year-old female seems to be the two most common age groups. Um, I'll add to what was stated and maybe add a little context. I really do like the Baton score. It is not a be all and end all, but it is a test where, for me, and I think I have this right, you check five different areas. And so it's little finger hyperextension of the MP joint, thumbs, can you get them to the forearm? Elbow hyperextension, knee hyperextension, and ability to put your hands flat on the floor. I think I got them all. Um, and that just gives you a sense. There is no rapid process for genetic testing or other testing that I know of that really helps you all that much. A lot of patients will come in with a diagnosis. It doesn't really change my treatment. If they have a high Baton score, if they're complaining of the typical things, I treat them like someone with hyperlaxity. Do you do anything different?
No, I mean I think that a lot of the patients and who I'm talking to about this have come in with a diagnosis or they have self-diagnosed, where I start to think about, maybe I'm probably not as good of a clinician or doctor as this surgeon that wrote in, but I'm not typically thinking about this diagnosis except in the setting of suspected mid-carpal instability in that demographic that you were describing, or thumb CMC instability in that demographic in which they are younger than I would expect to have thumb CMC issues. And it is more of a laxity issue with pain. That's when I'm starting to think, asking our resident fellow, did you do a Baton score, et cetera. My opening line is, oh, yeah, anybody ever told you, are you double jointed or quote, loosey goosey? And I quickly check the small finger MP extension. That's kind of my way of just briefly introducing that into the exam because for me that's been the easiest one to do and is pretty sensitive in that population.
Yeah, and the Ehlers-Danlos diagnosis, I think, is not for us to make, which is the most common hyperlaxity I think that we see in the States. But you're right. I think we have now hit on the three areas. One is midcarpal instability, two is CMC instability of the thumb, and three is just vague ulnar-sided wrist pain. And I would say this, I start the care of these patients exactly like I would start the care with any other patient. That is therapy therapy for strengthening. I think a lot of these patients come in having been splinted for 4 months. And while splinting in the short term, and we should have a therapist to discuss this with, but splinting in the short term can make a lot of sense, but ultimately it deconditions whatever part you're immobilizing. And so that can be counterproductive in this group. And so short-term splinting is okay to calm something down, and then therapy to strengthen and work on proprioceptive activities, I think is always a good step. So what would you add to that?
I don't really have anything to add with regards to the therapy piece. I think where I struggle with is the counseling about if the therapy doesn't work, what do we do next? So I guess let's go condition by condition, but just common things. Say you have thumb CMC instability in a patient with suspected or confirmed hyperlaxity. Does your treatment algorithm change? And if you get to the surgery decision making, do you do anything differently in terms of what you offer them surgically?
Yeah, I try to avoid surgery in this group. No offense to the group as a whole, but I just think surgical failure risk is higher. So try to avoid it. If it's unavoidable, I tend to lean towards bony procedures. My discussion includes bony and non-bony procedures, but let's say it's a 40-year-old female with CMC instability. If she does not have arthritis, then I will, and I'm pushed towards surgery, I will offer an Eaton procedure. So using FCR slip or hemi-slip to stabilize the CMC joint. If there's any hint of arthritis, my recommendation will be CMC arthrodesis. I think I worry about CMC arthroplasties no matter what you may do. FCR, I worry if you're doing an internal brace or whatever, suture suspension plasty. So I try to avoid those procedures when there is arthritis. And if there's not, I still talk a lot about bony procedures rather than soft tissue procedures.
So interestingly, this listener brought this particular scenario saying that she has a 40-year-old patient, 40s, with severe thumb CMC arthritis. And so you're going the arthrodesis route. This listener thought perhaps a tightrope type procedure might be more appropriate, so you don't have to rely on her tissues if your normal suspension is soft tissue based, such as an FCR or a sling of some sort. If you are pushed into the arthroplasty, non-implant arthroplasty domain, are you doing something similar with either a tightrope or a suture tape suspension of some sort?
Yeah, I just think either of those, yes, that makes sense. The listener is absolutely correct, but it still ultimately depends on the body's ability to provide scar tissue and secondary support. Because no matter if it's a suture tape or or a tightrope, they're going to fail eventually. And so I just worry about that. So I would lean towards a bony procedure. If they're not willing, then there's a risk of failure, and that has to be discussed up front. That has to be documented for new grads. It's just the risk of this age group and this population.
So yeah, I think that, in general, we tend to think that the risk of complications and reoperation is higher. Trying to get better about using AI based on our past conversations. So I did go to our friend Open Evidence, which I know is not the best one, but is probably pretty good. It's interesting. It had some suggestions, but I think it missed some papers based on then following up on the references. And, so there's some newer evidence that is relevant. But in general, they talked about how complication rates may be higher, but it's not really confirmed in any sort of studies. One thing they mentioned was local or regional anesthesia may be ineffective in a substantial proportion of EDS diagnosed patients. And then rehab has a higher role, which I think is intuitive. And then preoperative recognition matters. Outcomes appear better when a surgeon is aware of the hypermobility diagnosis. Would completely agree with that. And then one thing I'll say is that there's a newer article that came out from the group at UCLA, senior author Cody Azari. They did a cross-sectional survey of new patients presenting to a hand surgeon's office. So this is in Los Angeles. They looked at 210 patients with hyperlaxity, and this was 6% of all new patients in this hand surgeon's practice, which was twice the expected rate. So that's interesting. And then to our listeners' point, the hand clinic provided the first orthopedic evaluation for 46% of the patients, which was also interesting. So joint hyperlaxity is prevalent in hand surgery clinics and is likely underdiagnosed. And then those patients were most likely to complain of wrist pathology. So, and oftentimes the hand surgeon might be the first musculoskeletal clinician to see that patient. So interesting. Any thoughts on that before I have a couple of points I want to make, but we can finish up.
Yeah, I think that's really well stated and important information. And, the question becomes, where do we refer these patients? There's no hyperlaxity clinic, but, genetics tends to tackle these things in our environment. And then the one clinical pearl, which is not such a great pearl, but going back to our discussion of finger alignment after fractures, contralateral symmetry matters a lot. And so if there is symmetry in instability, but pain on one side, that just factors into how I think about treating. Ultimately, you're treating pain in this group or trying not to treat pain, but it does help me. Like for example, for midcarpal instability, if you're forced to treat someone after failure of non-operative care, I lean towards a bony procedure, which even though it's a more significant procedure like a scaphoid excision and four bone fusion, might be the right thing to do. Sometimes the patient won't consent to that, and you do something, including soft tissue, first, understanding the high risk of failure. And so those are long conversations that you have to have.
Any quick thoughts on ulnar-sided pain in patients with hyperlaxity?
Yeah, I think we see some of it. For me, you said it first. Midcarpal and definitely CMC are the primary two. Yeah, I mean, it's not an outstanding number of patients that have ulnar-sided wrist pain in this group, but I go through my typical assessment process. Is it ECU? Is it TFCC and DREJ? Is it something else? Which again, going back to midcarpal. So I do the assessment like I normally would, and don't know that my assessment changes based on a concern for hyperlaxity.
Yeah, the only thing I'd say that I've learned, and some would say the hard way, just in general, I counsel patients that I don't necessarily change the surgery I'm going to offer them. In, for example, say a cubital tunnel in a ulnar nerve transposition situation. Um, you know, but I will say that I think your outcomes are going to be somewhat similar, but there is a chance it's going to be more variable. And I think that just having that kind of honest extra line, I think as long as they process it, makes a difference. Because I do think there's higher variability in this population than patients without laxity. So I think that's an important thing to acknowledge just in general. Because this could be super challenging. And I applaud the listener for taking us on and emailing us because I'll be looking out for this more now that I've read a little bit more into it. I'm sure it's as our partner Marty would say, it's seen me. I may not have seen it.
Yeah, a couple of last caveats. Number one, many of these patients accept the challenge of their hyperlaxity and understand they are going to be more difficult to treat, and that's welcome. It doesn't mean you change your conversation. It doesn't, to your point, doesn't mean you necessarily do something different to start, but you have a different conversation and you lay the groundwork for potentially needing a more definitive bony surgery down the road. And again, for those going out into practice, be careful because, and I don't want to say anything derogatory about any patients, but you own these patients when you operate on them. And you can get yourself on a path with the patient that doesn't have a happy ending. And so this is one to be very careful with in surgical decision making. Even if it seems like it's straightforward, it may not be.
Completely agree. So thank you to those two that wrote in with your topic suggestions. Please send us anything you guys want to hear us talk about, handpodcast@gmail.com, or if anybody has any pearls themselves about handling patients with hyperlaxity or board prep, please email them in. And then also make sure you leave us a 5-star review on iTunes, or you can even leave your show episode ideas there as well.
Awesome. Yep. Love it. Fun conversation. I'm actually already looking forward to our next one. We have a couple we need to get to. We need to get to the new fellows, and then we have a Journal of Hand Surgery journal club, which I don't think we're calling Hand Surgery Journal Club, but whatever we're calling it, we have one coming up.
Spotlights.
Spotlights. Thank you. Awesome. Have a great day.
See ya.